Next on the lineup is going to be your IVs, PVACs or PVABs, and central lines. This is exclusively the pink packet. And it's got a lot of good stuff on it. I'm going to put little extra notes on it. If you turn, the first section I want you to go to, because we're not doing a hematology lecture, I want you to go to where this says Venipuncture. So you see it says aplastic anemia at the top of the second page, everybody? Okay, if you go down that page, we got some holy hookup here. Okay, we've got some things we've got to get to you real quick about venipuncture. I highlighted and made it real bold for you. How many sticks do you get? 2. How many of you have seen people stick folks 6, 7, 8 times? Don't you dare let me hear that you did that. Now, I'm one of the best. I'm so good, anesthesia has called me to help them. But I have never, nor would I ever, stick somebody more than twice. It doesn't stand up in court. You look like a fool when you damage their nerve. You cannot stick people more than twice. You can't do it because every time you do it, you think you got it. Now you think you got it for the 4th time. Now you think you got it for the 5th time. No, it's not worth it. Just 2 times. Please hear me on that, because that's a big legal issue. Okay? Do not stick people more than twice. And you want to document it. Okay? Unsuccessful venipuncture. And you do it twice. You just cover yourself nicely there. Okay? Now, don't be dingy. You do have to try twice. Oh, I just got out of school yesterday. I'm scared. I passed my test last week. I don't know if I can do this. Oh, my God. I don't want to do it. Oh, you better do it, because how you going to learn? So one of my nurses sent me an inbox. She said, I need your opinion. Did I screw up big time? Because I think I made somebody really mad. And she did screw up big time, and she did make somebody really mad. She said, I know that I'm not good with IVs. I remember I'm really bad at them. Plus, you know, I just passed my test 2 weeks ago, and this admission came in on evenings. He was really hypovolemic, and he was dehydrated, and it was long-term care, and, you know, there's nobody else there very much so. So she says, I didn't want to blow his only veins, so I only tried once. Wrong answer. You don't have a choice on this. You have to try at least twice. So when the next shift came in and she gave them that crazy-ass report, that nurse looked at her and said, I guess you better get your ass in there and try again. She was like, oh, my God, I know I'm not good at this. I don't care what you're not good at. You ain't poking twice. You can't talk to me. That nurse was right. That nurse is right. You have to try twice because you can't get good if you don't try. Yes, your patient's at risk because, you know you're going to miss. But it is what it is, you guys. You can't get good at it unless you try. So you can't try more than twice, but you better have tried twice. Okay, that's just real. In your real life, you better make sure you got 2 pokes. Okay? Now, you got a little bit of important shit here. Number 1, make sure you write 15-degree angle. Make sure you know that we don't like to draw any blood from an IV site. So if we're going to do a venipuncture for a blood draw, we don't like to draw blood from an IV site. Can you avoid it? Well, let me correct that because it's confusing to students. Let me correct that. When I start the IV, I get blood at that time. Now that the IV is already in the arm, if I have to draw blood, I go to the other arm. Does that help a little bit? Now, sometimes, a lot of times, your patient got an IV in each arm. So now what do we do? Well, remember it like this. You can only draw blood below the IV. You can't come above it. That's why we don't like to put things in the hands, and we like to go up the arm more, because we can, if we have an IV here, in the cephalic vein going up and around, if we have an IV here, we could do a venipuncture down here, But it's really not a good idea to go above the IV site ever. So I'm going to say that again because it's important. Never draw blood above the IV site. Never draw blood above the IV site. Only below. Okay? Now, giving you more little tips. Do you see where it says IV meds push slow to avoid hypotensive reaction? Everybody see that? Take that real serious. What was the only medication you could push super fast? Adenosine. Okay, so make sure you know that. Adenosine is the only medication you could push super fast. Everything else, I don't play with this. I go real slow, especially morphine. Adenosine has a short half-life. But every other drug, I push very slow, especially morphine. Dilaudid, all of that, real slow, okay? Something else on that issue. Never, ever push potassium IV, right? You don't ever give potassium IV push, ever. Okay? No LPNs is doing IV push. Nobody's doing that. What is that? That's crazy. And you know, I stand up here talking all kind of shit to y'all, and y'all be looking at me like, okay, Shelly, whatever. But we were just in class the other day, and the gentleman said his friend at work, the resident told him to push potassium IV push. Who was here that day? You remember? Okay. And what did the nurse do? She basically told him, go to hell. I mean, you know what I'm saying. She didn't say go to hell. But she told him, are you crazy? I'm not doing that. And he ended up getting chewed a new butt with his senior resident, right? And the senior resident told the nurse, good job. Excellent. Someone else might have done it. Then the resident himself, of course, a day later, came back and said, thank you for stopping me. I had no idea of the risk. You are the patient advocate. You are the stopgate between life and death and disability. You can't do what you're ordered to do. You got to do what you know how to do. And you know better than to push potassium IV push. I'll be damned, he said, push it. This was not that long ago. Okay? Now, some more things about potassium. Just because you know that damn drug is deadly. No more than 10 milliequivalents over 1 hour in a piggyback. No more than 10 milliequivalents over 1 hour in an IV piggyback. No more than 40 milliequivalents in an IV infusion. So that's where you have 1,000 cc's and you put in 40 milliequivalents. No more than 40 in an IV infusion for peripheral line. Regular routine IV, no more than 40. No more than 80 in a central line. No more than 80 milliequivalents in a central line. Use a pump 100% of the time. Use a pump 100% of the time. All right. Now, I want to point out to you that for your exam, you may have different language. They're never going to say peripheral IV. They're going to say either peripheral vascular access catheter or peripheral vascular access device. No both. An IV is that, PVAD or PVAC. That's your peripheral IV. And that messes a lot of you up. I've had people say, I thought it was the ventricular assist device, because at your job you work somewhere where we say VAD this and VAD that and LVAD this and RVAD that. And you're used to VAD as a definition, but that VAD, no, that's an IV. You've got to really read it. Okay, this is why we tell you to read every question twice. Okay, now, if you move to the next page, you'll see it says IV bags, IV tubing, blah, blah, blah. And I wrote something in really big capital letters. Does everybody see that? What did I say you need to do? Big capital letters. Check IV site every hour. What's the most important thing you're watching that site for? Oozing. Good answer. It's right next to it. Oozing. What is oozing at the IV site the first sign of? DIC. DIC, low platelets, thrombocytopenia. Man, you better watch it. I picked up on it immediately with my papa when he was getting chemotherapy. And I thank God I did, because we saved his life. Had I not been there to pick up on that oozing at the IV site, he'd be dead today. The nurse was not on the game as much as she could have been, but she was a good nurse, but she just wasn't that tight with it. So y'all ain't gonna be stupid. Y'all gonna go out here and be looking at the IV for oozing at the IV site. Okay, so OMG, I wrote that. Now, 3 things. You have, of course, phlebitis, infiltration, extravasation. What I wanted you to notice is I included extravasation with infiltration. There is no way you can have extravasation without infiltration, because by definition, it's leaking of a vesicant drug around the vessel. So I'm going to make that plain again. I'm trying to hook you up. Extravasation is a type of infiltration, but it's infiltration of a vesicant drug. So all extravasation is an infiltration. All infiltration is not an extravasation. The only time we have an extravasation is when you have leaking of a vesicant drug around the vessel. Now, I put in big capital letters 2 big differences. The first one for phlebitis, and by the way, nurses screw this up all the time. They screw it up all the time. For phlebitis, I gave you the capital word, the capital letters warm. Does everybody see that? Warm compresses. Capital letters. For infiltration, I gave you the capital letters of cool. Again, nurses screw this up all the time. Let me explain to you why you won't be that nurse. When you talk about phlebitis, phlebitis is inflammation but not infection. Inflammation of the vein, usually due to trauma from the needle, but it could also be due to a bunch of other things, but it's usually trauma, okay? Here's our problem. When you have inflammation, you have an activation of platelets. When you have an activation of platelets, you can get a clot. Do we all agree? Okay, if you give warm compresses, you create vasodilation and you allow for the blood to move through that inflamed vein better and not get stuck and clot. If you crazy and don't know what the hell you're doing and you put cool compresses, you increase the risk of a thrombophlebitis, which is a clot at the site of the IV. So you have to have rationales. Many of you, you go to toe-to-toe. I say, what's your rationale? You got to tell me why it's better to do warm than cold. Because without a rationale, you don't tend to comply or even understand or remember. If you're just doing memorization, you don't have a rationale. Oh, was it cold? Was it hot? What was it? I don't know. Eeny, meeny, miny, mo, page 4 on my notes. I think it was cool. No, you have to have a rationale for everything you do. Okay? Now, so infiltration, on the other hand, it's going to be cool because it's swelling of tissue, and edema responds very well to that, and it's going to feel better. So you want to remember these things. Can you do warm with infiltration? Sure. But you can't do cool with phlebitis. You can't do that. Now, let's give you some little hookups. Under phlebitis, we have to give you some really key terms. First of all, the signs and symptoms of phlebitis equals straw. So straw is easy. Everybody knows what straw is. And for shits, kicks, and giggles, just in case somebody don't know what straw is, what is straw? Swelling, tender, red, warm. Good. Okay? All right, so that's straw. That's what phlebitis is. In addition to that, highlight palpable cord, rope, red streaks along the catheter, and sluggish. Okay? For infiltration, some classics with this one, you want to highlight cool, pale, or mottled skin with blanching. And no blood return. Okay? Now, the next section you see is isotonic, hypotonic, and hypertonic solutions. For this, I want you to write certain areas that you would use these fluids in. For isotonic, this is again maternity, surgery, the emergency room, so trauma. Basically, anybody you would have gave blood to needs isotonic fluids, okay? So surgery, maternity, operating room, emergency room, those are all isotonics. Hypotonic, keeping it all the way real, rare. I don't give it as much, and maybe on, an obscure test here and there, but I don't give it as much. I rarely do. Hypertonic, oh yeah, neuro patients. Cerebral edema, ICP issues, big time. As you know, 3% sodium chloride is for SIADH. Question, everyone. Is that hypo or hypernatremia? Hypo. Because remember, everyone, that SIADH is another word for hyponatremia. Just trying to hook you up on your endocrine. It's another word for it. Okay. Yep. Midlines. Midlines are not central lines. Look at what I wrote. I wrote that in capital letters. I wrote not a CVC. CVC, central venous catheter, not a central line. On exams, it may not say central line. It may say central venous catheter or central venous access device. It is absolutely not a central line. Why? Because with central lines, the tip sits in the vena cava. With this, the tip sits in the axillary vein. This one, the tip sits in the axillary vein. Now, we love them. We love these IVs. They're used in long-term care, especially when a patient's been ordered 10 to 14 days of antibiotics, the way you do with osteomyelitis. So anytime I need an IV longer than, like 7 days or whatever, or more, obviously more than 72 or 96 hours, because remember, everyone, the peripheral IV, you have to start a new one after 3 or 4 days. Some institutions say 72 hours, some say 96. And you mad too, because you're the one that put that IV in there, and that was a good IV. And the thought of you having to take that good IV out and do another one, you are mad. But why are we doing that? Infection. So it's a foreign object in your body. It's going to set up an infection. So your institution may say 96 hours. Some institutions say 72. My entire life, it's been 72 hours. So I just roll with the 3-day rule on IVs. This is why you have to date them. Okay? So a midline is so wonderful because look how long it's going to last for a while. Look how long it's going to last. Usually a month or 2. Y'all see that? That's what's up. Who wants to get poked again and again and again? It provides for better dilution, but you still cannot give vesicant drugs. Now, what the hell is a vesicant drug? Pay attention to this. A vesicant drug, which is what I wrote under midlines, are drugs, everybody follow with me, that has a pH less than 5 or greater than 9 or an osmolarity greater than what? 500. Okay, so you still can't give that through that line. You don't want to give those kind of drugs through a regular IV. Those are central line drugs. Anybody can put in a midline, a doctor, a nurse, blah, blah, blah. X-ray is not needed. Oh, we might want to put stars around that. X-ray confirmation, not needed.